Welcome to everybody. Thank you for joining us today at this event from PDPAL project. These events are part of a series of webinars that will take place in the next few months and are organized by the PDPAL project consortium. PDPAL project is a project about palliative care for Parkinson's disease and is funded by the Horizon 2020 program of the European Union. We are very happy to start this series of events to communicate and spread the voice about palliative care. We are pleased to have with us today Victor McConvey, an outstanding nurse figure in the field of Parkinson's disease and palliative care. The focus of today will be testimonials and discussion of advanced care planning and advanced directives. The PDPAL project is still an ongoing project. We have still 9 months left before the end. We decided to start this project focusing on Parkinson's as it's one of the scenarios in which palliative care needs to be improved and spread. In fact, PD patients have a considerable and mounting unmet physical, psychosocial, and spiritual needs that needs to be addressed. We have different barriers and challenges that we have to face, and specifically face the problem that palliative care is linguistically challenging, as it is understood as a synonymous of end of life and terminal care. Our overall mission is to validate a new model of palliative care in Parkinson's disease, and that needs to be integrated in the Parkinson's disease management, especially in the late stages. And we want to do this by not only involving healthcare professionals, but also caregivers and patients. And our mission now is also to pursue this educational pathway to involve more and more students from healthcare professions to be familiar with this concept that we believe it should be a pillar in the care pathway of PD patients. The PDPAL consortium is composed by 10 partners from 7 different European countries. Our project was also recently joined by Region Skane University Hospital of London, who has joined our ongoing clinical trial. We have lots of partners join our project, like the European Association of Parkinson's Disease, and also other projects also funded by the European Commission, like iCarePD, that is also trying to improve care pathways for Parkinson's disease. Our objective to reach an improvement of palliative care in Parkinson's disease are developing guidelines and recommendations to understand better when palliative care should be addressed and delivered. And we are also doing a clinical study to assess the importance and efficacy of delivering a community care based on nurse intervention, which is aimed at better taking control of symptoms, but also it's allowing patients and caregivers to think about disease trajectories and disease course, and also to express their wills. And as I said before, we have also an important activity that concerns the educational part, and we have started with the pilot phase of the massive online open course, which is available at our website. If you go to pdpal.eu/MOOC, you will find additional information, and you're all invited to take part of this preliminary phase of the course that will be finally launched by June. I want to thank again all our partners that are part of the project consortium, and thank again to the European Commission and the EPDA that is supporting us, and again to the speaker that we have today, and I will leave the stage to him, and hope you all enjoy the webinar.
Hello, my name is Victor McConvey. I'm a nurse in Melbourne in Australia, and I'm also the chair of the International Parkinson's Task Force on Palliative Care, the International Movement Disorder Society, focusing very much on Parkinson's and other movement disorders. I've got a long background as a nurse, probably 30 plus years now, and have a very strong interest in looking after people with non-malignant illness as they reach the end of their life. So today I've been asked by my colleagues in the PDF Health Project to come and have a discussion about advanced care planning. So hopefully I'll be able to take you through some reasons why advanced care planning matters, and as clinicians, how we can support our patients to advanced care plan, and why in particular as clinicians we should have a role in that advanced care planning. So I'm just going to share my screen now to bring up a presentation. There we go. So that's who I am. I'm happy if anyone wishes to reach out, also just to shoot me an email on the email down the bottom if they would like any more information or clarification. So advanced care planning actually is a really significant thing, and it does matter, and particularly in the context of Parkinson's disease. Parkinson's is a slow progressive illness, measurable in decades, and there's an accumulation of disability over many years, which includes communication and cognitive change. It happens so slowly that sometimes people who are living with it and their family members may not realise that it's happening. Everyone experiences Parkinson's completely uniquely, and will have a different worldview as well. And that's a very important thing for us as clinicians to understand, that the tolerability of symptoms will vary from person to person. There is no one rule. We don't have any really clearly defined palliative care indicators, although some work that I've been doing with the Palliative Care Task Force is seeing some emerging indicators. And we also realise that in those areas where palliative care may happen and advanced care planning may happen well, particularly those hospice and palliative care agencies, they're often not available to people with Parkinson's. And certainly when I did some work with the MDS task force and we did a global review of palliative care services, we found there were often an absence of palliative care services. The services where they're available were under-resourced and had very much an oncology focus. So access to people with neurological illness, particularly with a slow progressive illness such as Parkinson's, was quite restricted. In fact, sometimes not available at all. There often was no neurology input into palliative care services. So we had agencies that were very skilled at managing oncological disease floundered when they went to deal with a patient with neurological illness. Even with some of the fast progressive neurological illnesses such as motor neuron disease, they struggled to actually palliate effectively. And certainly one of the things we did ask in our attitudes to palliative care survey was, what would some potential clinical indicators for end of life be? And things such as recurrent pneumonia, frequent falls, cognitive change, and increased care stress were indicators to consider palliative care. And one thing that we know is that those things can happen slowly, and advanced care planning needs to have happened before getting to those particular symptoms. One thing that's very integral when we're thinking about a long-term neurological illness, whether it be Parkinson's or even some of our atypical Parkinson's conditions, is that understanding of quality of life. So quality of life is integral in developing those advanced care plans, and is very much an individual construct, and is very abstract and quite dynamic, and people's quality of life does change. But the World Health Organization says quality of life is an individual's perception of their position in life in the context of culture and value system in which they live, and in relation to their goals, expectations, and standards. So we know that this is a really dynamic concept with people. It's abstract. It's not necessarily logical sometimes, and it might change into response to a life event. And so for little clinical grounding, recently a patient of mine, he was a lawyer, very focused on what his quality of life was, what he decided his endpoint wanted to be. And he had quite advanced Parkinson's and was getting some recurrent chest infections, had clearly spelled out that he didn't wish to be transferred from his residential care setting to an acute hospital. He'd been there, found it very unpleasant, recognised that his family sometimes were quite distressed when they saw him. He had some communication difficulty, particularly when he was during an off period, and had been quite open with us, sort of saying that if my life ended now, it wouldn't be a problem, until his daughter fell pregnant, and it was a long-awaited for pregnancy. She was in her early 40s, and he was determined to see his grandson or grandchild. It was a grandson as it was, and he sort of said, "This is very important. I want to be there for her, even though I might not be able to be there as much as I'd like to be. I want to see my grandson." And so during that 9 months, there were some intercurrent illnesses, and he wanted them treated, which include on one occasion a stay in hospital with intravenous antibiotics, which he found unpleasant. But this was particularly important for him. And the grandchild was 3 months old when he developed a significant chest infection, and had indicated that he wanted to revert back to his original plan. So it's a really dynamic construct for people, and we need to give our patients the agency to change and allow them to have conversations with us as to why they want to make changes. If that change is because they're frightened, we need to use our skills as clinicians to actually allay those fears. So we have a very interesting intersection between neurology and acute medicine. And neurologists tend to come from acute medical areas. We treat neurology in acute hospitals. And certainly in Australia, many neurologists, particularly general neurologists, who may not have a movement disorder focus, which is unfortunately where the majority of people with Parkinson's are often seen, is they often have a view of the world where we often treat until you can't. And sometimes we have experiences with patients who sort of say, my neurologist has said to me, there's nothing else he can do for me. Don't make another appointment with me. From a movement disorder perspective, we know there's always something we can do. And so my job at that point is usually finding a more appropriate neurologist. We know that medical advances have really significantly improved quality of life. We know that our treatment choices can be confusing, and patients, particularly if they're from a non-medical background, may be willing to accept whatever treatment we offer them. So as clinicians, we need to actually consider that we might need to step back a little bit and sort of say, making sure we're offering treatment choices that are, yes, you can have a treatment choice that will prolong life, but we need to step back from quantity and also have a discussion around quality of life. So we need to be really very aware of those concepts that our patients might not have actually considered, and also give people permission that sometimes it's okay to accept or want a treatment that doesn't necessarily prolong life. So meeting some of those challenges, we introduced some advanced care planning legislation in Victoria, which is the state where I live in Australia. And we know that prior to 2016, we have multiple points of legislation. We had formalised medical power of attorney that you give to anyone without actually necessarily having a discussion about what treatment you'd want. It was confusing as to who we could identify as medical decision makers in healthcare. And we realised that sometimes we were seeing patients who the clinicians were thinking, we shouldn't be treating this patient, we're prolonging suffering. But in the absence of any direction or being given direction by someone who maybe had no idea what the patient's wishes were, we were often compelled to treat. Although sometimes we felt this just doesn't feel right. So in 2016, and between 2016 and 2018, we had a really comprehensive community, legal and legislative review of what we're seeing there. And in 2018, we introduced having the conversation, which was a patient-focused program with a large publicity campaign. And we developed some advanced care planning resources, training programs, and with a particular focus on non-malignant illness, because we identified that these were the pressure points. We knew that if you had cancer, you often look very well within oncological circles and transition nicely into palliative care. With other illnesses such as dementia, Parkinson's disease, and other progressive neurological diseases, it was harder, it was more difficult. And so we needed the legislation change to allow people who died of that 70% of our population who dies of a non-malignant illness to actually develop some resources around what their care wanted to look like, and formalise that in both an advanced care planning process, which was a conversational process with those people who they wished to be their medical treatment makers, or to be appointed as their formally decision makers, and in a formal advanced care directive. It was supported by both federal and state governments, although in a federated country like Australia, we've all run at different speeds in developing and delivering this legislation. So it's not uniform across Australia, but it's getting there. This was supported by a large publicity campaign. We now have an advanced care planning week, where as health practitioners, we focus very much on that week. Unfortunately, what we've discovered is that short of that week is that our actual output and uptake of advanced care planning has still been pretty low. And we can see that less than 1% of our population have a valid advanced care plan that has then converted into an advanced care directive. And it's about 3% who've had that discussion, but that advanced care plan actually hasn't formalised into a directive that we can actually lodge within our electronic medical record. So we realise there's a lot more work to do, and also have realised that even with a publicity campaign and some focus on advanced care planning, we don't always convert to actually getting that directive where we need it. And interestingly, we noticed that female, single people, and people who are living with two or more comorbidities were more likely to have an advanced care plan in place. I was in a meeting yesterday looking at palliative care issues surrounding the LGBTIQ community, and interestingly, in that minority community, what's actually also been raised is the importance of advanced care planning when we have a hospital system and a healthcare system that might look at kinship as opposed to finding a medical decision maker, as opposed to a chosen family. And we realise because of religion and culture divides that many people who are from the gay, lesbian and transgender and intersex community may in fact identify people from a chosen family as opposed to a blood family. So we realise there's more work to do, but also there's actually more work that communities might need to actually take upon themselves to actually promote the importance of doing this as well. But when we look at when that discussion should occur, we found there was a little bit of a clinical conundrum. There was often uncertainty about when that discussion could occur. And often neurologists felt that on diagnosis, it was too early. Patients didn't want to have these discussions early, but healthcare professionals often felt the discussion should happen earlier. That uncertainty often resulted in the discussions not occurring, or not occurring until there was a critical event, which might actually be a little bit too late. So it's a case of actually having a discussion that's earlier and timing it. And it might not be the time the patient thinks is the right time, but it might be something that when we use our clinical skills and acumen, combined with that assessment of that patient's ability to have a robust conversation and cognitively manage it, and they've got enough emotional support, is to raise issues that might be something that I think as human beings, we'd much prefer to leave swept under the carpet for another day. So in particular to some specific interventions, we need to be really aware that if we trundle along and don't have some challenging discussions sometimes, we may get to the points where we're needing to consider a specific intervention. It may be a slow progressive change in Parkinson's. It might be much faster in a typical Parkinson's condition. So that's the progressive supranuclear palsy, corticobasal degeneration, and multiple system atrophy that as movement disorder professionals we all care for as well. And looking at interventions such as ventilation or peg feeding, we might need to be particularly aware that there can be some altered motivation for these tubes. We found in Australia in particular, and this extends to some stuff that certainly I've read about happening in other areas of the world, is that this can be an intervention that is fast, is relatively non-invasive, and has that capacity to prolong life, although some of the stats on peg feeding suggest that it doesn't necessarily prolong life, and the timing, if we're going to put a peg tube in, is particularly important to balance quality versus quantity of life. But we need to consider the motivation for this. I know that in my jurisdiction, Australia, and often in the United States, there is some slight financial, although not covert financial motivation for doing it. But often, a few times removed, some motivation where there's clinical coding. That means that people get paid a higher case mix rate or per diem funding within the aged care sector if they've got a peg feeding. There's often some supplemental feeding, supplemental funding to pay for the enteral feeding as well. In some areas, there may be some moral or faith-based things like we should prolong life if we have the technology available to us. And I've done in one part of my career when I worked in motor neuron disease, I did some work in Japan. We saw that often people with advanced MND or ALS in Japan were often provided with ventilation as well as peg feeding, and we ultimately ended up with a patient who was locked in, who was unable to tell us they didn't want something treated. And you saw that initially families would come every week to see that person, then they would come maybe once or twice a year, and then maybe they just stopped coming at all, which was particularly sad. So we need to be very aware of those things. And that was very much based around culture. And I found similar cultures of treatment when I did some field work in Sri Lanka in Parkinson's disease, just prior, in 2019, just prior to the world changing. As we all know, the last 2 years have been upside down. And emotional, particularly for someone who might be that medical decision maker. The fear of I'm starving someone to death, or I'm choking someone to death because I'm not saying yes to that tracheostomy, can be overwhelming if they don't have the adequate information to help make those decisions and interpret what may be popped in an advanced care plan to actually actualize that. When we're looking at those advanced care planning, and ideally before we get to this point, we've actually done some advanced care planning, who should be involved? And we actually realised that everyone needs to be involved, should be patient or healthcare professional initiated. We might need to use our skills to use that clinically identifiable time, and make sure the family or the identified significant other, and make sure the person with condition actually understands they've got choice as to who their significant other is. It doesn't necessarily have to be a family member. It might choose to be a child rather than a spouse. It might choose to be a friend if you have some changed family structures. So it will vary as to who that decision maker ultimately might be. Interestingly, some of the research that Nimmons and his group found is that often patients expected the neurologist to have the discussion. Yet conversely, sometimes as clinicians, we thought the patient should take the initiative. So we can see that those two individual perceptions that we're not talking about actually conflict with each other. And in a group, and I run a peer support group for people living with atypical Parkinson's conditions, and we talk about condition, about treatment management in the first half of our meeting. In the second half of our meeting, we divide carers and family members and people living with atypical Parkinson's into two separate groups. And every time we run this meeting, the first question that is asked by both groups is, how am I going to die and when am I going to die? But they won't ask it in front of each other because they're frightened of upsetting someone. So I think as clinicians, we need to be aware that sometimes we can raise these really, really difficult discussions, and actually people may well be relieved that they've actually got a face of someone who's actually willing to answer and understand these often complex sort of issues. And we can't actually ignore the pandemic that's been part of our lives for just over 2 years now. We know that certainly some research that I was involved with around palliative care responses with Ray Chowdhury and his group, and we published this, and there's going to be a further text associated with this being developed at the moment. We know that our advanced care plans did support people with Parkinson's to stop unwanted interventions, and they were particularly valuable when there was so much other disruption in healthcare. During one of our waves in Australia, and Melbourne was dubiously has the honour of being the city that was the most locked down for the longest period of time in the world. During one of our waves where we saw our aged care facilities significantly impacted, we saw many staff furloughed out of those aged care. We had a surge workforce who were unfamiliar with residents placed into aged care. And we had, unfortunately, we saw many people with advanced Parkinson's develop COVID-19 infections. And as an external clinician who was often asked to provide input, often the first thing I was saying, this person has an advanced care plan. The advanced care plan identifies that if they got a chest infection such as pneumonia that was likely to be overwhelming, they would not want to be treated. They would want to be palliated. I know COVID-19 is an external bug that we weren't thinking of when we did this advanced care plan, but we are dealing with someone who now has a likely overwhelming chest infection, and we should palliate as is their wishes. And we need to take the family through what we're going to do. We need to treat the respiratory dyspnea. We need to treat the stiffness of muscles because we can no longer give them their Parkinson's medication. And we need to allow this to be a central event in their life and they die. And it took a lot, and it was conversations happening over and over again in rapid succession. But it's something that's very important to understand is a really valuable conversation to have. And then when all else in the world is upside down, we still need to reflect upon those wishes that have been documented. And as clinicians, step away from the crisis for 5 minutes in our brain and think, what is the likely outcome? I've dropped a slide in also about voluntary assisted dying, which we see is available to people across the world in variable sort of levels. I know in the Netherlands they have a very open that program as they do in Switzerland, and we have a voluntary assisted dying program in Victoria. It's not available in all states of Australia. And interestingly, this program was developed at the same time we developed our advanced care planning legislation. And many of us who helped shape advanced care planning in Victoria also shaped and sat at the same forums to develop this legislation as well. And this was passed in 2007, so at the same time as we were doing the advanced care planning stuff. It's been reviewed and versioned and has really strict criteria. And the key criteria is intolerable suffering, again, which is a dynamic, quite personal construct, and didn't necessarily have to be intolerable pain that was hard to treat. It could be intolerable suffering from emotional trauma or other perceived suffering from the patient. And the application encourages, in fact, actually really channels you down an avenue where you do some very comprehensive advanced care planning. What we discovered when we looked at the most recent results of the last 2 years, 32% of people who had a voluntary assisted dying plan in place died before that was ever enacted. And when we looked at the non-malignant group who actually were putting their hand up to access the program, we discovered that 62% had neurodegenerative diseases. And I've got some stats briefly of people with Parkinson's, and surprisingly, about half the people had Parkinson's who were accepting the scheme, which is an interesting statistic that certainly I need to ponder a little bit more about people accessing this program. And is this because palliative care services are not necessarily open to people with Parkinson's disease? So maybe we're getting to a point where there is a service that could support someone at the end of life but is not available. So we are experiencing a bit more suffering than we need to. And I need to do some more work, and I've got some more work planned around to explore these issues a little bit more. But just to finish up with, we really need to understand that our patients and our families have lived with Parkinson's for some time, but they may well be confused by the legal changes and the legal framework. So we might need to take the initiative with them. We always need to consider cognitive change and the point in the illness where that's likely to maybe impact decision making. And potentially with Parkinson's disease, where you've got some cognitive change, where you may have some delayed processing, do we need to look at the environment that we're doing it? Do we need to make sure that we've employed our multidisciplinary team who know the patient well? And in particular, a neuropsychologist who can often give us some really great information on the patient's setting to make decisions and whether that patient actually has that legal capacity to actually make decisions. We ideally want to have these discussions before there's a crisis. We need to consider individual health literacy and how variable that is. And sometimes from that ivory tower of being a health professional, we think everyone understands the same thing we do, and maybe not understand that, yes, he might be a highly regarded academic accountant and lectures at universities, but he actually might not know much about his own disease process. And so we might need to consider that from all walks of life, health literacy might be variable. We need to allow people to use language that they're comfortable with. It needs to be ongoing and understanding it's a dynamic construct. It might change because of an event. It might hasten because of an event. You might want to slow down because of an event. And trusted health professionals are trusted resources. So building that rapport with the people that we care for is incredibly important. And being open to have discussions and sometimes maybe even leading those discussions. So that's the end of my presentation. So I'll stop sharing my screen and I'm happy for any questions.
Yes, thank you very much, Victor. Providing us an insight into what I personally think is a very, very messy subject, if we want to summarize it like this. And why is it like this? Maybe I have extensively worked with patients before I got to know palliative care, and I've done many interviews with patients and been patient's advocate. And my interviews have always been this kind of narrative interviews, very open interviews, which have pointed out that, which are of course much longer than the normal conversations with physicians or any clinicians. And I have learned from those conversations that for example, the notion of quality of life might be in the morning different than in the evening, for example, depending on how medication is functioning or depending on life events on that day, or someone just being mean to you, or you not liking the weather. So and from this experience, I have been myself also a little bit worried that how this kind of advanced care planning can actually function, because as long as people narrate, they can reconstruct their life. And narration is exactly for this purpose, that you can retell your life events in a way that they are more presented in a more positive light, even though, but this advanced care planning discussion could seem like a very negative, even an existential conversation. So, and so this might be something why people don't want to discuss it as you presented us, and if I just and that's why my hesitance also, that so can we make this advanced care planning stick, actually, because there have been already many studies also that say that maybe we need some kind of different format for these discussions, maybe more often, and renew this as long as the cognitive capacity is still there. So you see, it is not even a question, it is just a discussion here,
Absolutely, yeah. And it is developing your advanced care plan and identifying those persons who are going to be your medical decision maker is very much an iterative process. As you sort of said, you could have a bad day, and you've got in your mind, I'm going to do my advanced care plan today. I'm going to have that discussion with my general practitioner about what my wishes are going to be, which is very important in the way we do it in Australia. But you've got there, your meds aren't working well because you're constipated, you're off, you've had difficulty finding the parking, it's rained on the way into the clinic and you're a bit damp, and you've had to wait too long in the waiting room. And so by the end of the day, you're feeling miserable. Your mood is suppressed because you have not enough dopamine on board because the meds aren't working well. And it's probably the absolute worst time to have that advanced care plan. And you can't think clearly to actually identify that that's a bad time to do it. So it is very much an iterative process that needs to be ongoing. It needs to be a regular conversation. And often one that as health professionals we may need to lead and discuss. Encourage people that advanced care planning is not about death and dying. It's actually about, ultimately, it's about you having some power over the treatment that you might want. And also sort of say that, yeah, you've got an advanced care plan that sort of says in these circumstances we wouldn't treat. But it's a grey area when we get there. We are always going to turn to your medical decision maker and sort of say, yeah, the advanced care plan says this. However, I think given that this is not likely to be an overwhelming chest infection, if we provide some antibiotic therapy, we may in fact overcome this and have a restoration of our previous quality of life. And have a conversation as clinicians with family, and reassure people that it's not black and white. It's not a line in the sand. It's actually a process that changes and flexes over time, and that as clinicians we will always have discussions, even when we think we've got to that point. We'll make sure that you're informed, as well as the people who you appointed as your medical decision maker. In Australia, what we're also seeing is to assign a medical power of attorney, so someone who would be your agent when you're no longer able to make medical decisions. Is what they've done in many states in Australia, including in Victoria, is that you have to go through to appoint a medical decision maker. It's not just signing a form, it's actually going through a process where you're having wishes and discussions with the person you wish to be your medical decision maker. You have to have that before you can appoint them. And you've got other people, such as general practitioners, also verifying that those discussions have taken place. So it's actually, the legislative process is now forcing you down to have that advanced care plan. Whether that's the right thing or not is yet to be seen, but certainly it's an important change that we've seen here, is that the process, you actually have to have a discussion to get to the end, whereas previously you could go straight to the end.
Yes, but yes, because you said also about this, that these conversations have to be timely, because timely is the word that is very much now used in particular in neurological diseases, that you have palliative care has to be timely. And you briefly mentioned that it is difficult to really put your finger on when is the right time to have this conversation. So, so from your experience, because yes, there is data, but what is your experience? When is this conversation timely?
It's a really difficult one. So I would normally start the discussion with people in a couple of different forums. So if I'm talking to a peer support group, I will often raise, as some of our frequently asked questions, about advanced care planning. I'll drop the question in there when I'm doing a public presentation, in the same way as I drop a slide in about medical cannabis. It's often a thing that people might want to ask, but they might be worried about asking. I will often raise issues, particularly when I'm dealing with my atypical group. I often raise those issues very early with families. And so that patient education is really important. Letting people know that as a trusted clinician, I'm happy to talk about these issues. And there may well be some times when we are making some significant clinical decisions around someone's medical treatment, where we're starting to see that maybe oral medication control is getting harder. We're seeing more fluctuation. We're often seeing non-motor symptoms being significant during fluctuations, which is really impacting on quality of life. And we know the non-motor aspects of Parkinson's often have a greater impact on quality of life than the motor impact. Often making sure that we're starting those discussions and timing those discussions to occur during on periods when thinking is likely to be clearer and mood is likely to be more stable. Excuse me. So the timing of that discussion is particularly important in the context of the day, not just in the context of the disease, to make sure that we're having it at a time when someone is probably at their best and they're able to reflect on maybe that being off, what that's like, and that they don't like that. And understand that Parkinson's is a variable condition. And the longer we progress with it, there might be more feelings of being off, and that there will be accumulation of disability over time. And it's not just a single point of discussion, it's actually often continually raising and making that as a point of my consultation when I see people.
So now I come to your professional role, because you are a nurse, of course, and we or you spoke about this kind of trusting relationship, and usually this trust, of course, is invested into physicians, into neurologists, and people expect major decisions from their doctors. This is evidence-based fact. Even existential discussions they wish to have actually with their doctors primarily. So now the trend goes more towards nurse-led practices also in this area, and also in our lectures that we have prepared for our students, we suggested that specially trained nurses ought to make this kind of advanced care plans kind of with patients, because they maybe it has something to do with their patient's mobility as well, but the nurses then can choose the time when they visit the patients at their homes, for example, and patients can determine what would be the where they are on the top of their cognitive abilities. So after taking medication, after getting ready, and then they might say, nurse comes and has this discussion. Have you ever faced some kind of trust issues because of your professional role, and patients saying that, no, I want to discuss it with my physician?
Absolutely. I mean, there are particularly some of the older clients are much more patient doctor focused, and often don't necessarily understand the role of the multidisciplinary team, may have and that might be evidenced in the way they don't access things such as physio or speech, even though you think there's a clear need. We see much more collaborative practice in Australia now, because we realise that that neurologists in particular have a really limited time. And so we actually start to see much more of a multidisciplinary approach to managing care. And so I see less of that need for the care to be driven very much by the doctor, and we see patients much more willing to accept input from other healthcare professionals, including discussions around advanced care planning from either a nurse or one of the things that actually has happened is that we've developed a training program where anyone can become accredited to have those discussions.
Oh, okay, so that would be even volunteers having these discussions.
Yep.
Okay,
yeah, but
so
it's an accredited training program called Respecting Patient Choices, and it's about setting scenes for advanced care planning discussions, and sort of saying this is how you do it with your family or your chosen family, and that the next step is your GP, and sort of says, oh, when you go to your GP, you need to ask for a long consultation, because it might take 45 minutes to work through the paperwork. So we've got a lot of community ambassadors who are actually doing this, and so it may well be that the patient comes along to the movement disorder clinic and they're only seeing the physiotherapist. The physio is working with them, doing some mobility work, looking at some falls and balance. And that might be that we know physio is often the primary practitioner patients see other than a neurologist. And it might well be that, oh, I've heard about this, I'd like to talk to someone about this, or, you know, that chest infection wasn't very nice, don't think I want to go through that again. And the physio may will say, well, actually, maybe you need to talk to the social worker or the nurse who works in clinic, who's done the Respecting Patient Choices, who can talk to you about advanced care planning. So we know that there's a network within healthcare agencies and community agencies of people who can actually have these discussions.
Yeah. And then maybe my final question, and then you comment on something that I didn't ask, would be regarding, because you said about the tube feeding, you know, and this is has to be very fine-tuned, and you mentioned many reasons why it is done, and it has something to do, in my opinion, also with our perception of food. And if we eat, we get healthy. And so it might be relatives or even faith communities also pushing for tube feeding. And I have had many good experience in this regard with chaplains who come then and clarify family that why this maybe is not necessary, or why it maybe is necessary. It depends on the situation and the correct time, of course. What are your experiences from your region in Australia working with chaplains regarding food, eating, and also tube feeding?
Generally, they've been quite good, and often chaplains and pastoral care workers who may in fact have a direct relationship with hospital are often very good at taking people through that this is not, you're not ending someone's life by saying no to a feeding tube. And often we found that they're very respectful also of clinical practice, and often sitting down with someone together, with a family, with the patient, and having that discussion around, from a clinical perspective, me providing reassurance that over time, as what you've eaten has reduced, people have stopped feeling significant hunger or thirst, the chaplain sort of providing that spiritual support that this is a normal part of life, and that you aren't in fact starving someone to death, is often a really good way as in duality, to actually sit with someone, particularly someone who is a patient of faith, who is sort of concerned or uncomfortable about an intervention that's possible that might prolong life, and saying no to it, and taking people through the process and giving people the permission to sort of say no. It is actually okay to say no. You don't have to have that, and having that in a way that it does not become a dramatic discussion between life and death. That there's gradations. The other thing I would always say in context of these discussions, and it may not be relevant to Europe as it is to Australia. Australia being a very, very big country, where often medical specialists are concentrated in city areas. If you're 5 hours away from a clinician, and that might include a speech pathologist, I would sort of say you need to seek that clinician's view of how can we manage a swallow, and that from someone who's trained to actually do that, rather than just sort of say, well, we're going to bypass the speech pathologist because the only speech pathologist is an hour's drive away and she's got an interest in pediatrics. It may well be linking that speech pathologist with a movement disorder speech pathologist to get, again, that clinical background to actually work out, can we avoid this discussion anyway because we can modify diet and fluids. So that clinical aspect from a range of clinicians plus a spiritual leader is really, really important. And acknowledging this is that intersection between spirituality and clinical world. And as uncomfortable as it might make us sometimes as clinicians, we have to accept that and really realise if we're giving holistic care, that is a really important part of our patients' lives.
Yes, and of course, Australia is also religiously rather and spiritually very diverse country. So you need many well-trained people who can also address this area and help them to make other decisions concerning life. So maybe now I give the final word to you. That is there's something that you think now after our conversation you want to get off your chest, so to say, or everybody who's listening to remember for their practice and praxis.
Well, thank you very much for asking. It's certainly a topic that's very dear to my heart, and that this is not a clinical decision. This is a decision that we can do with our patients and their families and their people that are significant to them, whether it be a chosen family, it might be a pastor or chaplain, or even a nun that they like. We need to have the right people around the table when we're having the discussion. Sometimes we as clinicians need to set the scene for that discussion to take place, and understand that we have clinical skills that go beyond keeping people alive. We have clinical skills that can understand people's social and emotional and spiritual choices, and we need to weave that into our practice, particularly when we're getting to discussions about advanced care planning, and ultimately the biggest decision someone going to make in their lives, which is about the treatment they want will either prolong or maybe in fact shorten a life. But thanks very much for asking me to talk on the subject.
Yes, thank you very much.